So good evening, everyone. So we welcome Alka ma'am to this webinar 166 on diabetes and pregnancy. Thank you, Alka ma'am, for taking up this session. So, ma'am, we can begin.
Okay. Now, today we are going to talk about diabetes and pregnancy. Most of you may be family physicians, and you will wonder that why I'm talking about diabetes and pregnancy, because many of you don't conduct the deliveries. However, there is so much to learn about it and so much to practice about it with your patients, because diabetes has become like an epidemic in our country. As on today, documented number, there are more than 10 crore people who are diabetic in India. 136 million, that means 13.5 crore, who are pre-diabetic. So you can imagine, and many of them now still may be undetected. So we have this as an epidemic in India. Large number, 1 in every 5 people is diabetic. Now, naturally, there will be women who are diabetic. They may be in the reproductive age and they can develop diabetes. And then there will be questions about conception. Now, as you all know, diabetes is age old. Even Ayurveda has described it as Madhumeha. And when I don't know what were their testing tools, but at that age also, they have differentiated between Madhumeha, which is diabetes mellitus, Udakameha, which is diabetes insipidus, Ikshumeha, that is renal glycosuria. They have also defined type 1 and type 2 diabetes, and Ayurveda also described, because it has a genetic basis, it is incurable. So see how inquisitive people were, how observant they were, and how they have concluded and given that classification of diabetes which stands till today. When we go to the Western world, it was described by those people, but it was till 1869, nobody knew how can we treat this diabetes. It was a medical student, Paul Langerhans, who detected islet cells of pancreas. He knew that these cells are different from the pancreatic cells. However, he couldn't detect its function. And then there were other people who went on working with it. 1894, it was Lagwitz, Anatomy Hall, and he detected anti-DM activity of islet cells. And then the famous experiment of Banting and Best in 2122, anti-diabetic hormone, that is injection insulin, that they injected in the dog, and it was MacLeod and Collin, 1922-23, they purified this insulin. And all these 4 people were awarded Nobel Prize. Way back in 1949, Priscilla White from Joslin Clinic, she noticed the problems with pregnancy and diabetes. And she has reported, and this is documented in Joslin's book, spontaneous abortions were seen in 25%, fetal loss 18%, there were stillbirths and neonatal deaths. And she reported way back in 1949, I'm saying, macrosomia and metabolic instability in 80% of the newborns. So since then, pregnancy and diabetes has become a big issue. Now, what happens in pregnancy? Normal pregnancy I'm talking about, and then we will go to diabetes. As you know, in pregnancy, there is a conception. What is conception? A new human structure, de novo, is arising during pregnancy in mother's womb. New human structure. It develops, it matures, and expelled out at completion of gestational period. It's a rapidly growing tissue transplantation, that is conceptus. So you know, when we transplant another organ in human body, there is a reaction from the body. And therefore, we give immunosuppressant drugs, as you all know, in renal transplant, liver transplant, and all. But this is your own baby, and therefore, the nature affects the immune system of the woman. The immune reactions are suppressed so that the fetus can grow in the mother's womb. But at the same time, it also alters maternal fuel metabolism, alters the hormonal levels in the or hormone profile in the woman, and this is all facilitated by placenta. And that is how the fetus grows in the mother's womb, matures, and at the end of the completion of gestation period, it is expelled out, delivery. Now, what happens? There is an increase in estroprogesterone level during pregnancy, which causes beta cell hyperplasia. Therefore, there is increase in fasting insulin levels. This increase in the insulin levels decreases the fasting blood sugar. It is also because there is increased plasma volume in early pregnancy. There is a fetoplacental glucose utilization and anabolic effects. So in short, there is an increased fasting insulin level in the mother, normal pregnancy I'm talking, and decreased fasting blood sugar level. We have to keep it in mind when we see a pregnant woman. And accordingly, we have to advise her about her nutrition. Now, what happens in diabetes? You know what I would advise the family physicians? You may not be conducting deliveries, but you must be getting patients during antenatal period. But even before that, you can start counseling about pregnancy and the medical disorders. And major one amongst them is diabetes. It's a non-communicable disease. It is multifactorial, heredofamilial. Obesity is a great risk factor, and sedentary work is again affecting this glucose metabolism. So whenever these people come to you, you must advise them about these factors and so that they can change their lifestyle. What are the otherwise complications in diabetes and pregnancy? There's a fetal or neonatal death. There is a congenital malformations. Although you have nowadays sonography and other genetic testing, all malformations could not be diagnosed. And if it is many a times, if it is a malformed baby, there is an abortion. There are preterm deliveries. There is a preeclampsia, macrosomia. The baby is overweight, but still immature because the organs have not attained the maturity. Because the baby is big and because of the complication, there is increased need for cesarean section and there is a higher maternal mortality. Congenital malformations in the fetus is because of hyperglycemia, metabolic substrates, oxidative stress is increased, free radicals are increased, and all this causes mitochondrial swelling, and therefore there are congenital malformations. Therefore, what is necessary is to control the blood sugar level in the mother. Therefore, preconception couple counseling is very, very important. Now, whenever you see other types of patients also, you can talk to them. You can train one of your assistants or one of your staff nurses for this type of a counseling. And therefore, you can tell the patients that you have started these counseling services for pregnancy-related medical problems or medical problems during pregnancy, how they can be tackled. So the couple can come to you for counseling, particularly the newly married couple. But even otherwise, you can tell the parents, your patients, to send their children who are about to get married so that you can do the counseling. Now, preconception counseling, before they plan for the conception, both the spouses should do their CBC, urine examination, blood sugar fasting and postprandial, HbA1c to see their glycemic levels, serum creatinine, blood group, blood VDRL, HIV 1 and 2, HBV, that we do HBsAg. Suppose if one of the partners is HBsAg positive, we can protect the other partner. Secondly, if the mother is HBsAg positive, there is of course guidelines how to protect the child and how to immunize the child. Anti-HCV antibodies, serum TSH level, so that we know the basic TSH level in the mother, and the X-ray chest, so that we don't have to expose this woman to radiation during pregnancy. As you know, tuberculosis is so common in your country, and the MDR TB is increasing very rapidly. Many a time this remains, without any florid symptoms, and therefore, before conception, X-ray chest would be better, so that to rule out this tuberculosis or other. Vaccinations also should be done before conception. So vaccines consisting of toxoids, killed bacteria, killed viruses can be given during pregnancy. But vaccine consisting of attenuated viruses are contraindicated. Like mumps, measles, rubella should not be given during pregnancy. So also vaccine for yellow fever. So please remember, if anybody comes to you and inquires about yellow fever vaccination, which is nowadays given at the airport, there is a dispensary at the airport. But remember, it should not be given during pregnancy. So this all forms a part of your counseling. Vaccination which can be given during pregnancy are hepatitis B, hepatitis A vaccination, swine flu can be given, COVID-19 can be given at any time. Vaccines not to be given are MMR, varicella, yellow fever, and BCG also should not be given during pregnancy. Now, diabetes and pregnancy. As I told you, the diabetes has become so common that many women are diabetic. Some of them may be in the reproductive age, and therefore they are already having diabetes. There may be young diabetics, type 1 diabetes, okay, what we used to call it as juvenile diabetes or insulin dependent diabetes. Nowadays we call it as type 1 diabetes. Nowadays, many girls who are educated, they are career oriented, career minded, they get married late, and they also postpone the conception because of many pressures, and therefore they can develop, as the age advances, they can develop type 2 diabetes. Risk factors remain the same, and major one is obesity or overweight and sedentary lifestyle. Also, when they're earning enough, they consume a lot of food which otherwise can be called as a junk food. So these are the risk factors. Mother who is known diabetic, comprehensive pre-conception counseling is needed. Well-controlled blood sugar and HbA1c is a must before conception. Diabetes management during pregnancy and labor has to be discussed with her, and postpartum care. Okay, and therefore, a non-diabetic girl should plan the pregnancy, and she needs an extensive counseling. Not only she, but it is called as a couple counseling. So we have to give education regarding diabetes to both the husband and wife, lifestyle modification if it is necessary, medical nutrition therapy if she is obese, overweight, she has to reduce the weight. Now, when she has this diabetes before the conception, psychosocial evaluation has to be done. We must teach her self-monitoring blood glucose, and all this can be done by a family physician. For this, there is no need for her to go to a consultant. Most of the times, obstetricians never spend their time on all this because these are medical problems, and therefore you will be the successful doctor and counselor for these patients. Glucose control prior to conception is necessary, and therapy modification is necessary if the person is known diabetic and on the treatment. Lifestyle modification, reduction in body weight if there is a high body mass index, time management, which is very essential, regularity of the meals. Type 1 diabetes, type 2 diabetes, particularly type 1. Regularity of meals is very, very essential because the patient will be on insulin in type 1, and therefore, if she misses a meal, she may go into hypoglycemia. Working pattern. Nowadays, in the metro cities, this is very important. The working patterns are different. Many women nowadays are doing the night duties, like nurses, like those people who are working in call centers, people who are working from home. They are also working continuously at night. And therefore, the working pattern is important. According to working pattern, we have to plan out their diet and the activity. Avoidance of stress is necessary. No smoking, no alcohol, no substance abuse. Few years back, I myself used to laugh at this item. I used to say, no smoking for ladies. हमारे इंडिया में कहाँ smoke करते हैं? But nowadays I see every corner. I see boys standing passively and the girls are smoking away leisurely. Large number of girls have taken to smoking, and therefore it is very necessary that we impress upon the parents as well as this couple that no smoking, no alcohol, no substance abuse for this couple who's anxious for conception. Psychosocial evaluation. If it is type 1 or type 2 diabetes, there is a psychological trauma. Therefore, we must tell them to accept the disorder. Attitude towards the DM has to change because people are surviving with diabetes for n number of years. It is like HIV. Today, I see HIV patients surviving till the age of 67, 70. The oldest patient today I have is 70 years old. Okay, so you can live with diabetes. If you can live with HIV, you can also live with diabetes. So attitude towards diabetes has to change. Expectations of quality of life must be told to them. Structured psychotherapy, if they are so depressed or they have a lot of anxiety, they will require a psychotherapy and, if necessary, psychopharmacotherapy. Exercises. What type of exercises you will advise to a pregnant woman? Avoid supine position. Aerobic exercises contraindicated. Avoid fall, which will cause a fetal trauma, and avoid risk of imbalance. So based on these principles, you will advise them about exercises. The best would be walking exercise. Okay. And this is what forms a part of your counseling to the parents as well as to the newly married couple who are planning to have a child. What are the investigations? This is a known case of diabetes, okay, we are dealing with. So in this known case of diabetes, we will do CBC, we will do fast blood glucose, fasting and post-lunch. Now remember, this fasting and post-lunch should be done on 2 different days. Why? I'll tell you. Our laboratory technicians, they are so tuned to fasting PP, fasting PP, fasting PP. Even when I write for post-lunch blood sugar, they will tell the patient, kal kuch khaya bhi na aana. Now the laboratory opens at 9:30. Patient goes fasting at 9:30. After collection of blood, 10 o'clock, she comes home. And then she either skips the breakfast or many technicians tell them, kuch kha ke aao. So the outside they will eat some batat vada, samosa and go. This is not their true lifestyle. If it is a non-diabetic, we have already advised them the diabetic diet and the timing. So therefore, if you want both the things, fasting is to be done today. Tomorrow at home, she can have her regular, the morning routine. She can have tea, then she can have her breakfast. She can take her insulin or tablets, whatever she is taking. Have her meals, and 2 hours after meals is post-lunch blood sugar. This is very, very essential, and please remember that even for your other patients, when you do fasting and post-lunch, in a known diabetic, it should be done on 2 separate days. Nowadays, with the American Diabetic Association, people give more importance to fasting blood sugar. Because if the fasting blood sugar is high, the postprandial will be higher than that. So instead of these assumptions, I like to do fasting today and post lunch tomorrow along with the medicines and see how effectively the medicines are suppressing the sugar. Also do HbA1c so that we know the glycemic control in last 3 months. Serum lipids, if it is a known diabetic, we should also do fundoscopy because retinopathy worsens during pregnancy. In every pregnant woman, we want to know the thyroid profile, so do serum TSH, TPO antibodies, ferritin, and microalbuminuria. So these are the investigations we will do in a known case of diabetes. Therapy modification, if the patient is type 1 diabetes, she is already on insulin therapy. But if it is type 2 diabetes, she will be mostly on oral anti-diabetic drugs, OAD. Okay. Now, during pregnancy, we have to switch over this type 2 diabetes also to insulin therapy. And therefore, even before conception, we will switch her to insulin therapy. So she gets used to taking injections either 3 times a day or 4 times a day, whatever is necessary, and therefore switch to insulin therapy. Stop ACE inhibitors because many diabetic patients may be hypertensive and on ACE inhibitors or ARBs, so please omit them. Also stop lipid-lowering agents. Statins are not given during pregnancy. So stop these statins before conception. What are the glycemic targets before conception? In a known diabetic, I'm talking. The pre-meal blood sugar, that means fasting blood sugar, should be 80 to 110 milligrams per deciliter. 1 hour postprandial, 100 to 155. And HbA1c should be less than 7 or as close to the normal as possible without resulting in severe hypoglycemia. So 80 to 110 fasting and 1 hour should be 100 to 155. 2 hours will be again should be 120. Okay. Now oral anti-diabetic drugs, they are not used during pregnancy because their safety, first of all, is not established. Secondly, most of these drugs are long acting. Now imagine in a pregnancy, this lady is having morning sickness. She keeps on vomiting. Her food intake is reduced. And in that case, if you are giving long acting drugs, which are going to act for 24 to 36 hours, we don't know what will be her glucose level. She may go into frequent hypoglycemia, which is detrimental to the mother as well as to the fetus. And therefore, oral anti-diabetic drugs, tolbutamide is not available, but chlorpropamide, glibenclamide, gliclazide, glimepiride are all not used during pregnancy. There are some recent research papers. There is a meta-analysis which I read, and they have said that metformin can be given and it is as safe as insulin. That means it doesn't lead to congenital malformations or hypoglycemia and things like that. However, this is only under research condition. Metformin causes lot of metallic taste, lot of nausea. In some people, the side effect is diarrhea. Now, when there is a nausea and metallic taste, naturally the food intake of the mother will be reduced. It will be erratic, and therefore she may go into hypoglycemia. Therefore, oral anti-diabetic drugs are not to be used, but I am also not in favor of metformin. And if you see the oral hypoglycemic agents in pregnancy are contraindicated in America and in Europe. Why? Because there is inadequate safety data, lack of control trials, long duration of action of all these drugs, and non-flexibility of dosing. Okay, so suppose if she has lot of vomiting and her food intake is very little, then we can reduce her dose of rapid acting insulin. But we can't do that with glimepiride or other oral antidiabetic drugs. So please do not use oral antidiabetics during pregnancy. They should be stopped before conception, and the patient should be changed over to insulin therapy. Therefore, again, as a family physician, you can teach them how to monitor the blood sugar, how to adjust the dose of insulin, how the insulin injection is to be taken. It is to be taken on the abdominal wall. Okay, so it is better that they use insulin pens, which deliver the accurate dose, and it is painless. Insulin is a gold standard, established efficacy. We are 100% sure that this insulin will reduce the blood glucose level. It is safe and it does not cross the placenta. So there is no risk of hypoglycemia in the fetus. Which insulins can be used? We have short-acting insulin, which are also called as regular insulin. There is a human insulin which is available, which is short-acting. And there are synthetic insulins, the new insulins like Lispro and Aspart. They're ultra short-acting. And today, because of the availability, we prefer synthetic insulin, Lispro and Aspart. It is to be taken along with the breakfast or lunch or whatever meals, because it is ultra short-acting. The action starts within 15 minutes and lasts for about 2 to 3 hours. So it just covers that meal part. Patient doesn't go into a hypoglycemia. So there is a flexibility of the dose, and therefore Lispro or Aspart are preferred insulin as short-acting regular insulins today. Or you can give them intermediate acting once a day or twice a day. Mostly it is twice a day because action lasts for 12 hours. This NPH we can give. However, now there are synthetic basal insulin. You know basal insulin, which are given at night at bedtime. They maintain the basal insulin levels in the body for 24 hours, but these are not approved by FDA as yet, and therefore neither Glargine nor Detamir are used in pregnancy. So in pregnancy, you can use human insulin, synthetic insulin, Lispro or Aspart, or NPH insulin as the intermediate acting insulin. What is the insulin requirement? Usually it is 0.6 units per kg per day. In first trimester, we can increase the dose to 0.7 units per kg per day. The patient is also gaining weight, isn't it? In the second trimester, we make it 0.8 units per kg per day. Now I'm giving you the total dose that is to be divided between 2 or 3 injections, depending on the diet that you have advised to the patient. In the third trimester, 0.9 units per kg per day, and at term, it is 1 unit per kg per day. Labor or elective cesarean section. Here we have to be careful, because when the patient goes into labor or when you have planned the C-section, the patient will be NVA. And therefore, this NPH dose at previous night is given, which is long acting, so we'll take care of next day for 12 hours. No subcutaneous insulin on the day of operation. We start normal saline infusion, and 1 hourly blood glucose is monitored. Now, this I am giving you as an information, because I don't know how many of you will be doing the C-section. But when the obstetrician is doing C-section, this is the job of an anesthetist, to monitor 1 hourly, to monitor the blood glucose, give small regular insulin boluses. Active labor, when it starts, we should give glucose infusion with insulin, but we have to see that normoglycemia is maintained during the labor or during the cesarean section. Delivery is over, the baby is fine with all your efforts, and now about the nursing mother. Nursing mother's caloric requirement will be 27 calories per kg per day. And depending on that, we'll have to divide our insulin dose before breakfast, before dinner if you are giving NPH, but along with that, we should also give regular insulin so she remains normoglycemic throughout the day. This, what I was talking about, was a diabetes which was present before pregnancy. Okay? It was during 1964, O'Sullivan and Mahan, they observed that there is an impaired glucose tolerance or hyperglycemia in pregnant women who were not known as diabetics. So that means this hyperglycemia or glucose intolerance was present only during the gestation. And therefore, they coined the term gestational diabetes. Have you followed this? Gestational diabetes. So GDM is typically temporary condition that occurs between the 24th and 28th week of pregnancy and usually resolves after the childbirth. So it's not a permanent condition. So it is occurring only during the pregnancy. But still we have to take care of that. So remember this, even a non-diabetic woman, when she comes for pregnancy counseling, you can even discuss with her about GDM so that she takes care of herself. She knows when to do the blood sugar and accordingly we can manage it. So by definition, type 1 and type 2 diabetes existing before conception is called as pre-GDM. GDM is gestational diabetes mellitus. So which was the diabetes which existing before conception is called as pre-GDM. And GDM is diabetes detected during pregnancy. So it is gestational diabetes mellitus. Gestational diabetes mellitus, what is the prevalence in our country? It is supposed to be 4.2%. It depends on the maternal age. If the age group is 15 to 24, then it is the prevalence is low, 3.6%. But if the age is advancing and more than 35, then the prevalence is 6.4%. There is a low burden of this in Northeast and higher in Central, Western, and Southern India. Maybe because of our food habit, lifestyle, these may be the factors, or there may be, genetic factors also. Now, ICMR had conducted the study. Sample size was 28,408 pregnant women. House-to-house survey was carried out. And based on the random blood sugar level, it is reported that GDM is present in 1 in 25 pregnant women. So it is not that rare. 1 in 25 women develop gestational diabetes mellitus. Now, pregnancy induces progressive changes in maternal carbohydrate metabolism that I have shown you in my second or third slide. As pregnancy advances, insulin resistance and diabetogenic stress due to placental hormones necessitates compensatory increase in insulin secretion. When this compensation is inadequate, gestational diabetes develops. So nature has already given the safety valves. As the pregnancy advances, there is insulin resistance and diabetogenic stress. What is the cause? Placental hormone. Now, because it increases, there is compensatory increase in insulin secretion. But suppose if this safety valve is inadequate, then the gestational diabetes develops. What are the risk factors for gestational diabetes? Advancing age at conception, obesity, a known case of PCOD where the obesity is inherent, previous history of GDM in previous pregnancy if she had GDM, and parity. As the parity increases, this increases. What are the causes? Beta cell dysfunction, delayed response of insulin to glucose load. That is gestational diabetes. Once we give normal person, if I give you 50 grams of glucose, within half an hour, the glucose will increase. This blood glucose level will be at the peak. At the same time, insulin secretion also will be increased, and this sugar will be brought down to basal level within 1 to 1.5 hours. But here, because of beta cell dysfunction, there is a delayed response of insulin to glucose load. Placental hormones cause insulin resistance. And which are these placental hormones? Mainly placental lactogen, growth hormone, prolactin, and cortisol. So these are all hormones which increase the insulin resistance. How do we diagnose gestational diabetes? It depends on the blood sugar estimation, and it is usually seen between 24 to 28 weeks of gestation. So please do the blood sugar estimation at 24 weeks and again after 28 weeks. Now on the right hand side, you see the International Association for Diabetes in Pregnancy, and this is our Indian guideline. So what should be the fasting level for diagnosis? If fasting is more than 92, if 1 hour is more than 180, and 2 hours is more than 153. That means here we give a glucose load of 75 grams and do the glucose tolerance test. Fasting more than 92, 1 hour more than 180, 2 hours more than 153. It is gestational diabetes mellitus if this happens around 24th week of pregnancy. Now in India, because it is difficult for a person to spend for 3 samples, then to come twice, today they come and you advise, and tomorrow they'll have to come in a fasting state and then do this. So we have a shortcut. And we said 2 hour post glucose, if the level is more than 140, it is gestational diabetes. So whether the patient is in fasting or non-fasting state, give 75 grams of oral glucose, and 2 hours after this, measure the venous blood sugar, and that if it is more than 140, that means insulin response is lagging. So if it is more than 140, it is gestational diabetes. What are the complications of gestational diabetes? Birth injuries. There is the shoulder dystocia and macrosomia, because the body, again, the baby will be overweight and it will be very difficult to deliver her vaginally. During this time, the shoulder dystocia can occur, or there can be other birth injuries. Now, to avoid this, naturally, she will require C-section. So again, there is a risk of C-section. What is the management of gestational diabetes? If you really see, it's little mild, isn't it? Comparatively mild as against the known diabetics, type 1 and type 2. Blood sugar more than 92 and 2 hours level more than 140, we call it a GDM. And therefore, the first treatment is medical nutrition therapy. So we try to control it only with the diet. Then in the exercises, the best is walking. However, if the fasting blood glucose is more than 120, then this patient is started on insulin. Medical nutrition therapy, carbohydrate controlled meal plan. We eat lot of carbohydrates. 60% of our meal is consisting of carbohydrates. So American Diabetic Association says less than 40% calories should come from carbohydrates. That means you have to curtail on carbohydrates. In India, we don't have guidelines, but vegetarians should cut down on the carbohydrate, and 45 to 50% of the calories should come from carbohydrate. Most of us are vegetarians, and therefore we don't believe in getting, from the non-vegetarian diet. So it is lot of, what shall I say, leafy vegetables and kachumbers, salads, that should give us the vitamins and the necessary calories also. The meal should be small and frequent. And ketone testing in pre-breakfast urine should be done if the patient is not at ease. So medical, because we are starving her. So medical nutrition therapy is carbohydrate controlled meal plan. Recommended weight gain in pregnancy according to pre-gravid BMI. So we always consider how the woman was before conception, because after conception she is going to put on some weight. So pre-gravid category, if she was underweight, if the BMI was less than 19.8, then we recommend her weight gain of 12.5 to 18 kg during pregnancy. If she was normal, the BMI was 19.9 to 26, then recommended weight gain is 11 kg to 16 kg. If she is overweight, 26 to 29 is the BMI, then the recommended weight gain is only 7 to 11.5 kg during pregnancy. So see how we are curtailing the calories and maintaining the weight. And if she is obese, that means BMI more than 29, the recommended weight gain is less than 7 kg. What should be the targets in GDM? The fasting venous plasma blood sugar should be less than 95, 1 hour less than 140, 2 hours postprandial less than 120, and A1C should be less than 6. So these are the targets for gestational diabetes. What are the postpartum considerations? As I told you, we try here medical nutrition therapy, we try exercises. If the blood sugar fasting is more than 120, she requires insulin. Insulin here again, we will use rapid acting insulin or short acting so that there is a flexibility of the dosage and so on. So now, if the delivery has taken place successfully, then what should we do further? Is this hyperglycemia or is this GDM going to be permanent? No, sir. This is a temporary condition during gestation. That's why we call it a gestational diabetes. So postpartum consideration, test mother at 6 weeks. Okay. By 6 weeks, she will be normoglycemic. And thereafter, annually, if indicated. What do I mean by indicated? If there is a family history of diabetes, if she is already obese, PCOD, her sedentary lifestyle, all these factors tell us that this lady who had GDM may be developing a type 2 diabetes later on. The development of type 2 diabetes varies from 3 to 70%. This 70% and high figures are because of the risk factors that I just told you. If there is a high risk like obesity, family history of diabetes, then we have to do it every year, the blood sugar measurement in this mother. Otherwise, there should be every 3 years. Now, the child is born normally, but because of this GDM, and then it is a precious baby, pampered baby, the childhood obesity is increasing. And there is likelihood if the childhood obesity increases, this child may develop diabetes. Therefore, when we talk about diabetes with pregnancy, we are concerned about mother, the fetus, and the delivery. And we don't stop at that. We also consider about the breastfeeding, and we also consider the sequelae of this GDM after the delivery. So even after the delivery, GDM, the blood sugar is reverted back to normal, test it at 6 weeks, and then every 1 year if there are high risk factors, otherwise every 3 years. So this is all I wanted to share with you, pregnancy and diabetes. Now all this is quite simple if you just... So this is very simple. Only thing, you must have the confidence, and you can tell all your patients that you have counseling services, how you can have their children who are going to get married should undergo this preconception counseling, what all tests are to be done, how they are to be vaccinated. I have already told you. If they are type 1 diabetic, then they require special care because there is a lot of psychological trauma. That type 1 either feels that I am not going to conceive, or if she conceives, what will happen to the baby, and so on and so forth. So that psychosocial support she needs. There are so many of type 1s who get pregnant, and of course there are problems in type 1 in conception. But once they conceive, and if we take proper care, they can go through the pregnancy very well. And GDM is, as I said, temporary condition, and therefore it is only during the pregnancy that it occurs. And if you take proper care, the outcome will be very good. So thank you very much. If you have any questions, please send them to Preeti, and I'll send you the written answers. Thank you so much. Preeti, back to you.
Thank you, ma'am. Yes, ma'am. Thank you for such a wonderful session as always, ma'am. So if you have any questions, you all can message me or put it in the chat box. I'll convey them to ma'am and get back to you all. Thank you. Thank you, everyone. See you next Thursday. Thank you, ma'am.
Attendance was less. Why? Because the topic was not of interest?
No, ma'am. Actually, what happens, everyone is in practice, so the recordings are viewed more. So tomorrow I'll put up the recording and it will have around 600 to 700 views.
Oh, okay.
Yes, ma'am.
Thank you. Thank
Yes,
you
ma'am.
so much. Thank you.
Ma'am, thank you
Thank
very
you,
much.
Preeti.